just had allergies. So once I like recognized that, and my tummy was hurting, it was really weird. Like everything was hurting. But then I got up onto my feet out of bed and I realized, hey, I'm okay. Actually, I'm actually not.
I feel like that's a good life lesson.
Yeah, you know, sometimes you just have to get out of bed. That sounds like way more depressing than it should, you know? This feels like an appropriate day to talk about mental health.
Mental health?
Yeah. You know, like the holidays are coming up and the days are getting shorter.
Yeah, the days are getting cloudier and that seasonal affect disorder starts to kick in.
I was going to say, I've noticed a lot of nurses look like significantly more depressed.
But I got myself a scrub jacket.
I saw
and
that.
Now that's my favorite.
I'm thinking about getting a vest.
A vest?
Yeah. But I already get like borderline bullied about my shoes. So I don't know if I want to get a vest. I mean, people were commenting the first time I wore a shirt, like a t-shirt, like a unit shirt.
Oh yeah.
On the floor, and they noticed that I had like worn a shirt.
Huh.
So I feel like I'm kind of not like in the spotlight, but like I'm definitely like have my
in the spotlight, in the hot seat. You were voted hottest man on the unit.
Well, only man on the unit. Well, we have some other guys. I was voted rookie of the year.
Rookie of the year? That's a thing on your unit?
Yeah.
Wow. Did you get a little trophy?
I didn't get jack for it, except really just the feeling, like the pressure that I should be doing better and like keep this up.
I feel like it's getting you the ladies though.
Man, someone told me that I asked like where they were because we're both single, and then I'm like, oh, what are you doing? And they were like, oh, I'm like asexual at the moment.
You did not say you were asexual.
No, they told me they were asexual.
Oh, I thought you said you were asexual.
But like just for the moment, they're like, I feel like I'm in a place right now where I'm just asexual. And I was like, I don't like necessarily resonate with that, but I get it, you know?
And on that note,
mental health.
You
just got a crash course in it right now.
Yes.
Psychologists could pick the first like 5 minutes of this apart and probably get like a decent diagnosis out of it. Anyway.
I'm David.
Matthew.
And this is the Handoff Report. That was gross.
I want to apologize right now for the sniffles. It's just allergies. I want to make that very clear.
So it's not COVID?
Not that I know of. I wish it were COVID.
I don't wish it were COVID. I'm sitting right here.
Well, yeah, but we could both get 2 weeks off. Paid. And then since we both have it, we could just hang out all the time.
Nice. This is the podcast about nursing stuffs and why it matters.
Yeah.
Today really matters. It's how we deal with patients who have mental issues.
Mental health, yeah.
Mental health. We're trying to be very respectful about this. We respect the heck out of mental health.
Oh yeah. I think it's one of those things that I think nurses, they have to deal with humor. Yes. You know, and jokes, because it can be like such a dark thing.
It can.
And you see it so often. You almost have to make jokes about it.
So specifically today, we're talking about people who are in the hospital for something, but they have, on top of that, they have a history of either a developmental disability, or they struggle with suicidal thoughts, or they have ADHD, or what have you.
They could be on the spectrum.
There you go, yeah. As opposed to talking about patients who land in a behavioral health hospital and they are there because of their mental health battles.
And that's a pretty big distinction about like what we deal with in kids versus adults. You know, like with kids, you're generally dealing with, at least on my floor, kids who have like established diagnoses that are, at least for the most part, managed. I mean, you know, every once in a while we'll get a kid who comes in and, you know, they're not managed at the moment. And that could be like a contributing factor of why they're there.
Yeah.
But for the most part, like they're at baseline for their like specific disease.
in the emergency department, some people do come to the ER because they feel like that's the place they should go whenever they feel like they're about to kill themselves. They're like, they have it in their minds that they are sick, that this is some kind of illness. So for whatever reason, they don't go to a mental health facility. They go to an ER. They go to the medical center. And we know that. So we have rooms dedicated to, we call them psych patients. And they are psych rooms. And you can take everything out of the psych rooms. You can take out all the supplies, all the cables, everything, and just leave a stretcher. That way, it's a psych safe room. We also have paper scrubs. Mm-hmm. We take away their clothes and give them paper scrubs. We lock away all their belongings. But when you have patients that are there for some like medical illness, but they have mental health issues, that sometimes can pose some challenges. And I feel like that could pose a lot of challenges if they're kids.
Yeah, no, definitely. I think it's one of those things where it can become a sticky situation really fast, especially when you're dealing with kids who have parents as well. Like they're not necessarily their own person yet, legally speaking. Like they're not able to make their own decisions necessarily. So it becomes kind of not like a custody battle type of thing, but it can turn into that where like the parents want one thing and the psychologist or the counselor like wants another, or the parent will say something like, well, I don't like really feel like they need this or that, where the psychologist is like, yeah, they definitely need to do this or that, whether it be like inpatient or outpatient. So it can be like a matter of adherence like to the prescribed thing that they want to do. So that's usually like the biggest thing we run into. And then it's just hard too because it's kids.
Yeah. I remember during school, I did a rotation in the pediatric ICU, but at that time, there were also some beds up there that were like overflow beds.
Yeah.
And so they weren't necessarily like on ventilators and a bunch of medications. They were just up there because that's where there was space.
Yeah.
And I remember for the first time seeing a very anorexic little girl who I think she was 12 and her BMI was 15 or 17.
Yeah.
And so she was there for the complications of that. She was, lethargic and very malnourished. And yeah, she was getting her nutrition from an IV because she was still refusing to eat. She would take medications, but not food.
Yeah.
And so she had a sitter because I think she had a history also of SI.
Yeah.
And so your plan of care has to now start including things like patient safety, I think, to a whole nother level. Like you have to be very watchful and not let anything slide, because it only takes a second of your back turned for something tragic to happen. And unfortunately that happens in the ER. But yeah, it happens with all psych patients. They're super unpredictable and they keep you on your toes. They tend to be time consuming as well. That's the biggest issue for me with psych patients in the ER. They're very time consuming. You don't spend a lot of time getting stuff done. It's like you're constantly having to take long breaks de-escalating things, and then they make you behind with your other patients. And
that's kind of like the heartbreaking thing about it is like you're there trying to help and it feels like you're banging your head against a brick wall, To kind of speak to that, I had this one patient. This was when I was still in orientation. They weren't my patient, but it was one of the patients was there for SI. And it was one of those where you screen them and they're super high risk, where they're actively having thoughts of hurting themselves, like history of SI attempts, cutting, stuff like that.
And SI stands for suicidal ideations.
Basically, it just means they're actively thinking about killing themselves. So this patient, since they screen high, we do like the safety checklist, environmental. It's a whole bunch of charting stuff you have to do. Basically, long story short, is getting everything out of the room they could potentially use to harm themselves.
Yeah, you have to chart their symptoms, and the way they ask it is really interesting. Do they have the idea but not a plan? And then there's something called safe room environment charting, and that's where you have to like specifically say there's no forks in there, there's no extra sheets in there, they're in paper scrubs, there's direct line of sight. That way, if something happens, it says somewhere that you took the precautions.
Right. And it'll go as detailed as like making sure the cords you use are the shortened ones.
Yeah.
Or like the shower curtains are gone. Stuff like that. Like anything you could do, use potentially. So they did all that, cleared the room, but the girl had like a paper mask. You know what I mean? Like the ones we use. And they have the flexible metal thing to mold over your nose. Well, what happened was, and this person was on a 1-to-1, which means they had a sitter there at all times. So the patient goes like under their sheets and ripped the little metal piece out and started cutting with it.
Wow.
So like that's an example of is like when they have SI, suicidal ideation. Like you have to be really on the ball.
I guess the mistake in that situation for me is that if she screens high risk, why is she able to go under a blanket?
And that's the thing, because like the nurse cannot be in the room 24/7. So it was actually the parent who noticed it was happening and not the sitter.
Wow.
It was like a whole thing. But that got some policy changed for sure.
Yikes.
Thankfully, like everything was fine. Patient was fine. Like it was just some scratches and stuff.
Okay.
But like that's all that to say, it can go south really fast if you're not on the ball. And that's something you wouldn't even, who would think of that, really? Like who would?
So, I wanted to end this episode with 3 examples of psych patients from the ER. Everyone likes good ER stories, right? But each of these examples highlight something, some kind of principle, some different principle about a nurse's approach to mental health and how to care about that. So this first one, so we had a guy, this like 6 foot, like strong built guy who came in for hallucinations, but he was also complaining of being short of breath.
Huh.
But he wasn't really short of breath. Like he wasn't really symptomatic. It was just something he said he had. He was very anxious, pacing around. I was trying to help out with kind of clearing the room, and he would pace the room and start like shadow boxing the wall. His nurse was a lady, and the doctor ordered haloperidol, which is a drug that in larger doses, we affectionately call it having the patient go night-night because it basically just has them go into a nice calm sleep.
That's what we call Ativan.
So I should stop and quickly say, just as a fun fact, it is illegal to chemically restrain somebody.
Yes. Depending on your healthcare facility.
Yes, depending on your healthcare facility. At my healthcare facility, or I don't know, my hospital, it's not like against the policy. It's also like illegal to use chemical restraints on a patient. It's not illegal to tie someone down to the bed. So a physical restraint. You have to follow guidelines to do that properly, but it is always legally improper to chemically restrain a patient.
I should say it gets a lot stickier with kids and using like 4-point restraints, and like physically restraining kids.
Yeah.
That we don't really do that a whole lot. And we don't chemically like sedate kids as well. Yeah.
But we while we cannot chemically restrain somebody, we can treat anxiety. So we always have to make sure that we're not giving a medication to knock somebody out cold.
Right.
For the sake of making our jobs easier.
Yeah.
if someone's presenting a danger to themselves and others because of hallucinations or like acute anxiety attacks, then we give them anxiety medications. And if those anxiety medications happen to sedate them a little bit, then that helps the patient, right? So anyway, so this
I'm like trying to defend you here.
this crazy guy, he's like one wrong word away from being violent against the nurses, right? And his lady nurse is holding like a syringe full of the haloperidol, and she was like, nuh-uh. She was like, can I get a male nurse to give this? Because I'll chart everything, I'll do everything else, but I would like some extra help. And the guys in my ER are more than happy and understand that.
Yeah, no.
That is, don't leave a 5'5" nurse all by herself with a patient like that.
No way.
So one of our guy nurses goes and gets it, and he goes in and says, oh, I'm going to give you this medication. And the patient is refusing it. Like, he doesn't want it. He like starts getting violent. Like, he starts getting real close to the male nurse. And so me and 3 other guys jump in, and we're like coaxing him just by our advantage in numbers. We're coaxing him back into the bed. So he sits down in the bed and lies down, and we're telling him, hey, yeah, we have this medication and it's going to calm you down. And so the male nurse says, okay, guys, like, hold him down. So that we did. Everyone got, like, I got a wrist, the other guys got his feet, one of them got his head, and the nurse like gave the medication. And he's like, he really hated it. He was swinging, he was trying to get out of bed, he was screaming. And then the security guys came in, and they were like just supervising. But yeah, they were standing at the door. And so eventually the guy was like, just get off me, just get off me. So eventually we all just got off of him to see what happened, you know? So he was lying there, he kind of stared all of us down, and then he got up from the bed, and the security guy was like, just get out of the room. So that was pretty interesting because these guys are experienced.
No, yeah.
I feel like they acutely know when the force is needed and when the space would, do better with handling him, So the security guy told us, let's give him space. So we left, and as we were leaving, he kept shadow boxing against the wall, and that for us totally was like, yeah, he wants to fight. He's trying to be all like macho and stuff, and so he like gets really upset at the male nurse that gave him the shot. He's like, who are you? He starts calling him names, and the male nurse, he just stares him down, pulls down his mask, and laughs. That's not necessarily like the best de-escalation technique.
Yeah, no.
So the guy really gets upset at him now. And he starts like wanting to say, I need to go to the bathroom. And everyone knows he means, I want to get out of this room to hurt that nurse. But he's like, I want to go to the bathroom. I want to go to the bathroom. So he like forces his way out of the room. And then the security guys, one of them just grabs him from behind and throws him 10 feet through the air back onto the bed. It was one of the coolest things I'd ever seen. I thought that John Cena music was about to play. Ladies and gentlemen, John Cena. He like almost lands on the other side of the bed. And I'll never forget the look on that patient's face when he just realized he'd been like...
Just like physically...
He had just been thrown through the air.
Well, he got manhandled is what happened.
He like took 3 seconds just sitting on the gurney.
just to process that all out.
With a blank face where he didn't look angry anymore. He didn't even look scared or worried. He like you said, yeah, he had to process that.
Man, I would have to process that.
Oh yeah, I thought that was so cool how he was stunned. So then it started to kick in eventually, but he kept complaining, it's cold in here. It's cold in here. Give me a blanket. Now we can't give him a blanket because he's not supposed to have anything in that room. So the nurse that had given him the shot, he was like, "Oh, are you cold?" He's like, "Yes, I'm cold." Keeps swearing up and down at him. So the nurse goes to the thermostat and turns it all the way down to 60 degrees. Because he's a punk. He's a gangster like that. So eventually, this guy got telepsyched and got sent to a behavioral health facility. I share that story to highlight that in the ER, there's a lot of violence that happens against the nurses in the ER. The point of that story is de-escalation. Like there were like a couple things that was effective at de-escalating, and one of them was like leaving this guy alone for a second.
Yeah.
Because sometimes just the presence of nurses agitates them. There's really no good way to learn how to de-escalate except going through it firsthand.
Yeah.
One thing that was bad at was not a good de-escalation technique was like laughing at the patient or having a lot of folks talk about him in front of him.
Right.
That just, you don't want to heighten any paranoia that they might have, because then they feel cornered and they start acting out, So I had another patient just the other day. I had like this 60-something-year-old. Okay, no, she wasn't my patient. She was someone else's patient, and I offered to discharge her for that nurse. I was like, "Oh, I'll help you out. I'll discharge your patient for you." And she was like, "Yeah, sure." And I realize now why she was enthusiastically thankful was because her patient was crazy. I walked in, and it's like this 60-year-old lady wearing a tiny tube top and sweatpants. And she had these markers, and she had been writing all over the sheets. She wrote all over her hand. She had all this like voodoo looking jewelry on. And she for sure was schizophrenic or something, because she was very paranoid and defensive about everything. I didn't even have to say anything, and she would start being defensive about something. And it was very early in the morning, so I did get mad at her because she started saying things like, "This is probably your first day, huh?" In front of me and my student. I had a student nurse there too. She was like, "This is probably your first day, huh?"
That's when the what is it called? The imposter syndrome really sinks in,
So, for a patient like this, I had to start using something called therapeutic communication. That's like a thing with psych nursing. For some reason, I feel like you should use it on all patients.
Yeah,
but
you should.
But they teach it to you because you especially need it with patients with mental health issues. Therapeutic communication is just really basic communication techniques where it kind of helps you soften your language and not sound accusatory. I think that's the way to explain it. So she's saying all these things and being defensive, and it sounds like she wants to argue, right? So instead of me arguing, there's like basic things you can do to make it easy to not engage in an argument. Is you just repeat what the patient is saying back to them.
No, yeah, that's therapeutic communication.
That is? Okay.
Yeah.
So she would say something like, you don't know what you're doing. And then I would say, "I don't know what I'm doing? Yeah, I got diagnosed with Parkinson's 2 days ago." And I was like, "Wow, Parkinson's?" And she would say, "Yeah, you don't know anything about Parkinson's. You don't learn anything on the floor. You only learn it if you're going through it." It's like, I don't know anything about Parkinson's? So it's basically, I was repeating everything she was saying, but in the form of a question. And so that was working for a while until she said, "This is probably your first day." Because then I stared her down and I was like, "You are disrespectful." I'm finding myself saying that a little too often. Anyway, so yeah, the charge nurse came over, and I love our charge nurses because they always have your back. The charge nurse was basically like, "Ma'am, just let him take you out of here. He's just doing his job." this is not his first day here. He doesn't have to tell you anything about his career. And I was like, wow, that's a nice feeling to be defended. It didn't work for me that time, but therapeutic communication is something that usually works. You want to avoid saying things like, why did you do that? You know, because that can sound accusatory. You want to start your sentences with, tell me more about blank.
Yeah, just like avoiding confrontational talk.
Mm-hmm.
Like it's not trying to like get what they're saying exactly. It's just talking them down, you know, talking them down. And that seems to be like the biggest thing, is like calming them down, you know?
Yeah.
Should I tell that last story?
Oh, yes.
Of like how things get violent.
Yes.
With pediatrics.
Mm-hmm.
And I know in your mind you're probably thinking of like a little 8-year-old going ham, you know? But I think a lot of times, like you're dealing with more like psychosis type stuff, whether that be like schizophrenic, manic, like full-blown psychosis, that kind of stuff. We're also dealing with like developmental and or like, so we'll deal with like ADHD, like severe anxiety, bipolar, kids who are on the spectrum.
Right.
And there's like a little bit different of approach you have to take. One, because they're kids, and two, just because like those illnesses have like, not necessarily illnesses, or they just have like different ways of treatment.
Yeah.
You know? So we had this one kid who was on the spectrum, and his mom lost custody of him. So grandma had custody. Grandma was in a wheelchair and was having a hard time kind of handling him, just because the kid was, you know, almost fully grown, probably like 6 foot, 200 pounds, like a big dude.
Yeah.
So we had him on the floor for a little while, and he had a history of getting really agitated and like physically aggressive.
Right.
So I walk onto my unit, and everyone's kind of like in a daze, you know?
Yes.
And I'm kind of like, what's going on here? So I'm like rounding around, and I'm talking to one of the nurses who's on night shift, and she's like 5 foot nothing, maybe like 80 pounds. And I'm like, hey, like, how's it going? Like, how was the night? And she's like, man, like that kid, I had him last night. And she starts telling me, and she says, so I go in there like late at night, and he got really agitated and upset and he wouldn't take his medication. So I was wearing my stethoscope around my neck, and he grabbed the stethoscope and tried to choke me with it.
Wow.
And then, so she like called out and was like yelling for someone to come in and help, because she thought this kid was going to kill her. So the night charge nurse goes in, and she's not really like a physically imposing person either.
Oh.
She goes in, and the kid lets the nurse go, so she runs. And then the night shift charge nurse goes in there, and this kid backs her into a corner and punches her in the face.
Wow.
So then the charge nurse is able to run away, and at this point he's really worked up, and he starts like beating up on his grandma.
Oh no.
So they have to call security, and they try giving him Ativan, but for some kids,
He fought it?
For some kids, Ativan has the opposite effect.
Oh no.
So it got him even more aggressive. So long story short, they had to try a bunch of stuff, and finally Benadryl worked and got him down. So that's all in the past. So the girl who's getting him is she's like taller and a little bit more built, I'd say. And I was like, hey, like, if you want, like, I can take this kid, you know, like, just so you like don't have to deal with that, and you know, just let me know if you want to switch. And she's like, okay, I'll let you know. And so she walks in, and this kid tries to choke her out.
Wow.
Too, with her stethoscope. And he's like slapping her and stuff, and then he starts beating up on grandma again. So it takes like security and like all of us standing by the door, because he's trying to like yank the door open and make a run for it. So I had to like hold the door closed so he couldn't get out. And then they had to call security, and then there's a whole bunch of people in there trying to talk him down. and all the hospitalists are there because like we need stuff, so we'll be like, hey, like we need Benadryl, and they'll be okay, get Benadryl, that kind of stuff. It felt like we were running a code.
Man.
So finally we were able to like talk the kid down and get him back in bed, but it's so hard, because you don't want to, they're kids,
Yeah.
and you don't want to hurt them, because that's the hard part, and no one wants to talk about this, is that if you do something, like we had this one guy who, a kid ran out of the room and one of the nurses tackled the kid, and the kid ended up like getting hurt or something happened, and the nurse got fired.
Wow.
And I think they got like their license taken away.
Shoot.
So that's kind of the hard thing, is like you can't, like, we're like trying to de-escalate, but at the same time, none of us wants to lose our license over someone.
Yeah.
I don't know. That's the hard part about working with kids, is because like if you hurt them, I feel like you're more likely to have something bad happen to you. So it's this like dance between staying safe
Yeah.
and like not doing something that could potentially get you fired.
Yeah, you got to know your policies.
Yes. Yeah.
Have witnesses
Please. Yeah.
chart your butt off.
Oh yeah. No. You better believe that they were writing
charting
an essay.
away.
Yeah. They wrote
writing
an
a
essay.
5-page essay on why I should not lose my license over this kid.
And that's the sad thing, is these people are just trying to help and keep these people safe, and they end up getting fired over it. It's tough. Tough stuff.
Well, that is psych nursing
Yeah.
from our perspective. I hope you found it as cool as we did.
No, this is like a really interesting part of nursing.
Oh yes, it's one of the funnest parts. But it also keeps you humble.
Yeah, I think it does.
Well, I'm David,
I'm Matt.
and this has been
The Handoff Report.